Welcome to the James Fund Neuroblastoma Family Retreat, and thank you all for attending. We are very happy today to have Dr. Meredith Irwin with us, who is an oncologist at Sick Kids in Toronto, and as well Denise Mills, a nurse practitioner. They are both in the solid tumor program, and they work with neuroblastoma children. So they are two of the people who care for the kids we love the most. And we're very, very honored to have them today. So welcome to you.
Thanks,
and thank
Diana.
you for coming.
Great, thanks. So I'm going to talk about a lot of things today. So I'm an oncologist. I'm also a scientist. So I'm going to try to give you a feel for a lot of different things. So I've picked what I thought were hot topics and things to talk about. But if there's things I'm not covering or things you have questions about, just ask me, because I can talk about anything for a long time. So, but I've tried to pick things I thought were sort of interesting in terms of where we're going with clinical trials and what we're doing in the lab, so that you can kind of get a feel for both ends of the spectrum. And then Denise will tell you about some exciting news in terms of where we are with starting MIBG therapy at Sick Kids very soon, pretty soon. So these are the things I thought I would try to cover. A little bit of updates on treatments, and so I'm fairly involved in the Children's Oncology Group in terms of a few leadership roles I have in developing clinical trials, so I'll give you a sense of where we are. Our meeting is actually coming up in a couple of weeks, but I know what we're going to be talking about, so I can update you. So I'll talk a lot about upfront treatment, but also about where we're going with relapse treatment, and talk a little bit about where we are with getting some of the genetic testing up and running at Sick Kids rather than having to send it all to the United States. And one of the superheroes. And then I'll also talk about there's many research projects that are very exciting at Sick Kids, but I've just chosen a couple to tell you a little bit about today. So I think, and I apologize if a lot of this is things everybody knows, but I didn't know sort of what the level of everybody's background is, so I'm just going to start where I would even when I'm talking to our trainees at Sick Kids. So a lot of what we do in neuroblastoma, I think we've really led the way for a lot of pediatric cancers in that we use a lot of different information to try to start to personalize treatment for patients. So even though it's not the sexy new personalized therapy you hear about, we've really been doing this for a long time for neuroblastoma. And that's because we take a lot of information about the children with neuroblastoma, just about their age and how far the neuroblastoma has spread, and match that with some fancy genetics and other markers to try to come up with what's the best treatment for the first child that presents that day versus the next child. So I'm pretty biased, and I think we've been doing precision or personalized medicine for a long time, just need to still go a little farther. So in doing that, we've actually tailored our neuroblastoma clinical trials in North America as well as in Europe and many other countries throughout the world according to these factors, and we divide our kids into these three groups that you can see in the pie, low risk, intermediate risk, and high risk based on their risk of the disease coming back. And listed are just some of the characteristics that we use, and the list just keeps growing as we get smarter in the laboratory. And what that tells us is that there's three groups of patients, and I'm going to show a lot of these curves, and I think most of you are familiar with them, but just in case, this is called a Kaplan-Meier survival curve, and this is the years from diagnosis for children, and then this is the probability of them being alive. And so if you divide patients, as we've done in the Children's Oncology Group for a long time now, into low risk, you can see it's over 90%, and it's actually now closer to 95, 98%. Intermediate risk is coming very close now. And then high risk, which unfortunately is still, as we all know who are here today, not as good as it should be. Oops, sorry. And so the types of therapy we give is actually also different. So we're not getting these differences just based on the children themselves. So for low risk, more and more, we just observe children and or potentially do some surgery. And even with that very minimal therapy, we're having that excellent survival. For intermediate risk, patients get a different number of cycles of chemotherapy depending on all of those fancy genetic tests that we do. And actually, this is the group where the genetics is the most important actually right now. And most of those patients get most of their therapy as outpatients and do very well. And then as you all know, high-risk therapy is just a lot. I heard it recently referred to as throwing the kitchen sink, and that's really sort of what it is. We throw surgery, intensive chemotherapy, stem cell transplant, radiation, and now as well biologic therapy with immunotherapy. And there's always talk of more, adding more, because we're not doing well enough yet. And again, this is probably something that everybody's familiar with. This is a slide I show to our fellows because they find it actually a little overwhelming when they start trying to understand all the different groups of neuroblastoma patients. So I've kind of made a simplified version for them where essentially for non-metastatic patients, it's fairly straightforward. They're essentially mostly patients that are not metastatic, so not stage 4. And then a few of our stage 3 patients have some genetics that makes them high risk. But really, it's the metastatic patients that I'm going to talk to you about today that are mostly high risk, except for some of our toddlers who have very favorable genetics. So I'm not going to spend a lot of time talking about the good neuroblastoma today, as we sort of refer to it in the clinic, the low intermediate risk, because we're doing really well. And because of that, I think there should be a lot more emphasis on the late effects of the treatment. And I know Mark Greenberg came last year and emphasized that a lot. So I'm going to focus a little more on the other end of the spectrum today. But what we are doing in COG more and more, and it's the same in the SIOP group, which is the main European group that studies neuroblastoma, is less aggressive surgery. So we don't need to get it all out. We know we don't need to get it all out. And that if all the genes look favorable in the tumor, the body will just take care of it over time, at least the residual that's left behind. That's taken people a long time to accept, but we know that's the case now. That's not the case for children who have the more aggressive form. At least we're not sure yet, but at least for the lower stage.
So now is more aggressive. The 1P is the deletion, 11Q.
Is that also a loss? So if you lose, oh, sorry.
We have like our daughter has the 11Q unbalanced. So is that?
So that's a tricky part. So remember that pie, as you know probably, the pie I showed you with the red, yellow, and green. So we do know that 11Q probably puts a few of the kids from the yellow to the green, but not all of them. There's many long-term survivors. So we're trying to understand, we probably have to match the 11Q with another couple of things.
Yes.
So this is the group that's the hardest for us. We actually need the most tissue, the most tests, because we need to really like dot our I's and cross our T's to know what the right treatment is for those patients. Because we think the right treatment is usually less, but we don't feel comfortable with that till we do all these tests.
Yes.
But we prefer to...
Less and had to do with it.
and often, so that is the flip side, we do find that a lot of these kids, we call it, we can salvage them or we can rescue them later on. So we feel that that probably means it's not fair to subject everybody, or not the correct thing to subject everybody to toxic chemotherapy if we think we can salvage them later. But I have many patients in my practice who have the unbalanced 11Q, who I'm transferring to the late effects program, but I also have some that have had progression or recurrence. But many of them are still alive. So we wrestle with that up front because we don't know which of those two pies they're going to fall into later on.
And is there now standard testing?
So that's a good question. Yeah. So we do it. So at Children's Oncology Group, it's been standardized in this test called FISH. Which is where they basically take these fluorescent little copies of the chromosome. They're red or green or whatever color. And if you have two, you've got the two copies. And if you have one instead of two, you've got the loss. We're doing a fancier way of doing it now. We're just starting that in our new trial 1232 that's going to open soon, where we do one of these fancy array things. You've probably heard of SNP arrays, all these fancy things where they take a tiny little thing and put the DNA and RNA on it and then stick it in a computer and all these things happen to it. That's what we're going to be doing. Awesome. And that'll tell you not just 1p11q, but a lot of other genes. And we think if we put all those genes together, I know I'm going to, Kirby knows I might get somebody if they're not careful. If we put all those genes together, we'll get a better sort of picture. So it's almost like a computer program now. The more things you have, you can plug out a better...
And will that be done for every patient? Like for us, we only did it after she had relapsed.
So any patient enrolled in the COG biology trial will have that attempted.
Okay.
We need enough tissue. It doesn't always work the first time, but it is done. And now the vice chair of the biology protocol, so we have a lot of people calling and saying it didn't work the first time, and we almost always just say, just send us more. If it's a child that it'll make an important clinical decision for. So we would like to be able to get it on absolutely everybody. That's our goal. We're going to be doing this at Sick Kids as well, but we still would send it at Sick Kids to Children's Oncology Group, but we will be able to do it there soon as well. So our focus really, decreasing late effects, and we observe more. So observation, I think, is the right way to go. It's actually very hard to convince families. As you might imagine, they go on the web, they get the James Fund, they read about neuroblastoma. But for some patients, it is the right thing to do, and we observe a lot of patients in the clinic, which means lots of ultrasounds. and making sure it's not growing, but most of the time they do very well, and we can spare them surgery, like when they're little tiny babies often. It's the right direction to go in, but it's taking a while. And we're a little behind Europe in that way, but we're catching up. But here's the real problem, and this is a slide I got from John Maris, who's one of the big researchers in neuroblastoma. This just shows you these same Kaplan-Meier's, but over multiple decades. And you can see that we're doing a little better now, but it took a long time to even just edge that curve up a little. And what's edged it up a little is the immunotherapy. So this is where we activate the body's immune system to fight neuroblastoma. And this is really for the high-risk patients. And this is Alice Yu, who's with Denise and I in Stockholm at the ANR meeting in the Nobel Prize Hall. And we think she's sort of deserving of that for being such a pioneer in the neuroblastoma field. Yeah, and she's about this big, but is a giant in the field and is the nicest person you could ever meet. And I think also a very caring physician who was at the bedside with all the first patients who got this therapy and really was a very caring clinician scientist and a great model. But this was the trial that showed that when half the patients did not get immunotherapy and the other half did, that there was a significant difference, almost 20% in survival. So this is now why we do immunotherapy, and I'll talk about that for all patients who qualify. But what's new and where are we going? So I could tell you where we've been, which is immunotherapy, but we always want to get better because that's not good enough. 50, 60% is still not good enough. So what are we doing to improve? So again, probably most of you know this, but I always like to think of treatment for neuroblastoma in 3 phases, and this is actually how we think of it in the children's oncology group. So we don't just come with one plan for the whole time now. We kind of have 3 separate phases, and each child, again, may not get the same things. So there's induction, which is the standard chemo. The different colors are just different chemos. We collect stem cells. We do surgery to take out the primary mass. And then the majority of patients go on to get a bone marrow or stem cell transplant. And then again, the majority of patients these days, if they qualify, go on to get immunotherapy. This is about 1.5 years. It's a lot of treatment, but it's led to these better success rates. So just the way I do when I take care of my patients and talk to families in the clinic, I'm going to tell you a little bit about where we're going with each phase. And some we're not changing that much, because if it's not too broken, we don't necessarily want to go after that. So first is this induction, just the chemo, the first 5 to 6 cycles of chemo. Truthfully, there haven't been a lot of major changes, and we actually don't think this is the place to put our money. We think we're doing pretty well because about 85% of patients will respond to that upfront chemo. Not all, but about 85%. And what are the differences now across both sides? So I'm going to try to give you an appreciation for Europe versus North America, when we're doing things maybe better here, maybe worse. So basically, we all do about 5 to 6 cycles. Europe loves cisplatin, carboplatin, those drugs, a little more than we do. Right, but hearing is a definite concern for that. Not that we do perfectly in the North American trials either, but we tend to add a little, we mix and match a little more and have added topocyclo and doxorubicin, and those drugs have their own side effects. But overall, I think we use a few more drugs at lower doses, so we tend to be biased towards this being the better protocol. The efficacy is probably pretty similar, and the Europeans are kind of moving in induction more to our regimen. I think because of the toxicity mainly, especially the hearing toxicity. So we're not really doing much with induction. We're doing little tiny things here and there, but we're not really going to change the therapy. But transplant is really where we're sort of edging a little bit, trying to make some difference. So remember, transplant, for those people who haven't been through it, is when we just give a lot of chemotherapy and basically give the child's bone marrow precursor or their baby bone marrow cells back to them to kind of rescue the bone marrow, because it would never rescue itself from that dose of chemotherapy. So we do think we can improve it. So the COG carried out a trial several years ago now where some patients got 2 transplants, some patients got 1, and we don't know the answer. We do know that at Boston and CHOP in Philadelphia that there was a suggestion that it maybe inched up the survival a bit. It wasn't as much as immunotherapy, but it did seem to help. So we're awaiting those results, but my suspicion is they're not majorly amazing, because the way we write our trials is if it was a home run, we would know, because it wouldn't be fair to...
Mortality, DMT?
So It used to be higher, and I say that just because BMT is not just the drugs, but the supportive care, and I think we're a lot better at the supportive care. So we generally quote to families for an autologous, where you get your own bone marrow back, which is neuroblastoma, it's probably 5% now, and I think that's probably overdoing it, because in our experience, I don't think we've lost a child in a long time during transplant itself.
2 versus 1?
So the protocol was written so that if there was an excessive toxicity or mortality, we would have had to stop, and we did not reach that. And that's the stuff Health Canada and the FDA all oversee. And in the CHOP, and when I was a fellow at Boston, we did this protocol. I didn't feel like we had more toxicity, and none of the reports seemed to show more toxicity, because if you have too much toxicity in number 1, you don't get number 2. So I think we're pretty conservative. We don't want to do any harm there. I think where the real money is, and I'm sure many of you have read about this or heard about this, is what are the chemo drugs for transplant, and can we do better? So this is where the Atlantic Ocean has changed things a bit. So in Europe, they've always loved these 2 drugs, Bumel, and in North America, we've always loved CEM. And until recently, nobody had really looked at them head to head. And I should just say, even when you look at things head to head, there's lots of caveats. It's not always a perfect thing. But in Europe, they did look at they sort of said, we're going to compare North America to ours in Europe, and we'll see what we get. And what they got, and I could show you lots of details, but I'm just summarizing here, is that in their experience, patients who got the Bumel did better than patients who got the CEM. We've spent a lot of time at COG and at collaborative meetings with the European group going through the data. It's not perfect data, so I'm not sure it's as amazing as they say, but I think we believe it's probably a little bit better. Again, all of these things I think are inching us, but if we can do them all together, maybe we'll make bigger milestones. So there's this possible improvement in neuroblastoma, in decreasing neuroblastoma, but some of the cons are that we definitely know the liver does not tolerate Bumel. And we've been doing Bumel for a while in Toronto, especially for kids who had a lot of hearing problems before getting to transplant, and we've also seen the liver problems as well. But we do know it's better for hearing, for sure. So that's a bonus if we go that direction. So again, COG, we knew about this data. It's still not published. We've known at COG for over 2 years about this data because of this collaborative interactions we have with the PSYOP group and vice versa. So for a few years, we've been planning to look at this Bumel, but putting it with our initial treatment. So we're kind of mixing and matching what we think is the best. We like our induction. We think that's the better chemo. And then we'll take what the PSYOP is doing for transplant and try to superimpose it and maybe hope to get the best of both worlds. It's not the most scientific way to do it, but it's, it would take another 5 or 10 years if we started comparing them all over again. So we don't think that's the right thing to do. And right now, we've already moved to even for patients who don't go on this new COG trial, we've already moved to switching most patients to Bumel.
So when you say standard of care at 6 kids, is that every kid going through transplant will get Bumel?
It's generally, unless we are concerned about the liver beforehand, which we rarely are, but there's the rare case we are, we would. And when I say standard of care, that means if for some reason the patient wasn't enrolled on the trial, either parental preference or it wasn't open at the time, something like that, we always have a backup that we say, this is what we would do if you don't go on the trial. So.
And is this just sick kids, or is this...
So it's a COG-wide trial. It's open, to my knowledge. I know within Ontario, it's open at most of the centers because we do the transplants for anywhere in Ontario and in the eastern provinces. So most of them have it or will have it open.
Can you bring out wet?
Yeah.
Would it be different out wet?
No, it shouldn't be. I just, because we don't do their transplants, I don't know. I know Rebecca Dale quite well, who's at UBC, and I know that their plan, they open all of the COG trials now. So I just don't know if today it's open. In fact, sick kids is sometimes the slowest just because everything takes a little longer at sick kids to get through. But it should be open at most of the Canadian centers. I don't know if you're all familiar with C17, which is this administrative sort of overarching group that helps us with opening all of these large protocols for Canada, and they help us with the first steps so that it makes it much faster to bring protocols north of the border.
This is the business of bringing 17 children's hospitals together across Canada so that they're working together as opposed to figuring it out.
Everybody trying to get it through their own regulatory,
Down in the States, do they still use the CEM?
So it's a good question. It's variable. It's very variable. Most of them have the protocol open, but what they do for patients not on trial is quite variable, and often depending on their transplant group and what they kind of prefer. But the experience in North America, you also, when you haven't done something, you don't know it as well. So in sick kids, we've been doing it a lot longer, so I think we were more comfortable in adapting to it. The nice thing about Canada, I'm an American, so maybe I could say this with it. In Canada is sometimes I think we do some things like the Europeans and some things like the Americans. We sort of pick our favorites. So I think that's a good thing, actually, that we're open to that. So what's another thing we're trying to do? So in addition, and I have the wrong number for this trial, after, I do have the right number. After this trial, the next thing we want to do is say, are there some patients who we know sometime before they relapse that they're going to relapse? So essentially, can we predict who's going to relapse before it happens so that we can maybe offer those patients something extra instead of waiting till they relapse? I don't know if that makes sense. But essentially, we call this in COG ultra high risk. So can we make that pie that was 3 colors, 4 colors, and predict which patients maybe need yet a different kind of treatment? And so the way I like to think of it, because I'm a pretty visual person, is, which of the patients that we know are sort of on average going to do worse than this, and then which patients are maybe going to do better than this. And if we can predict these guys either the day you walk in the door or after a few cycles of chemotherapy, maybe we should change it up and not give you the same thing that everybody else is going to get down the road. So we've done a lot of work at COG and now internationally at trying to understand if we can look for these different characteristics either at the beginning of treatment or somewhere down the road, but before here, and figure out if we can identify these patients. And I actually had the privilege of helping to lead a task force that did some of these early studies, and what we looked at was, are there some genes or other characteristics of patients the day they walk in the door? So just from the biopsy, so experimental studies we can do. Is there something we can look at after a few cycles of chemotherapy? And one of the things that's been done in leukemia for a long time that we're much better at doing in neuroblastoma is looking in the bone marrow or blood for very few cells we can't see under the microscope, but can we find like a little bit of their RNA or DNA, the sequences that tag them as neuroblastoma and not normal cells, and can we find that and detect it before it comes back to the bone marrow or comes back on an MIBG scan? And so we're doing that much more at the experimental level, but we're very close to bringing that to real time. And then the same thing, instead of just after 2 cycles, maybe it'll even be more apparent at the end of chemo and before transplants. So maybe we shouldn't be doing a transplant on certain patients, or maybe we should do a different kind of transplant. And so there were a lot of different things we did. And I'm just going to tell you about one thing, which is now published, that Greg Yannick out of Michigan led, which is to just look at all these MIBG scans we do on everybody and say, we kind of know it makes sense logically to us if there's still disease on the MIBG, that's probably not ideal. But he looked at it very carefully for 300 or so patients very systematically and scientifically. And what they found is if you compared scores at the beginning with scores right before transplant, you really could predict outcome. Not on everybody. There's plenty of patients who still have MIBG positive disease before transplant who are still doing fine. But if there's a lot, it's in this particular group of patients, it definitely told us that they had a different survival. And this isn't actually overall survival. This is just of the relapse not coming back. So this doesn't actually mean patients have passed away necessarily. It just means their neuroblastoma is back. So this just tells us who's not going to get rid of the neuroblastoma. So these are the patients we really want to focus on from the time they walk in the door and get smarter in the laboratory for these patients. And one of the things we're thinking of doing, it's not finalized, but one of the things we're thinking of doing is for these ultra high risk patients, maybe offering them MIBG therapy, which we'll hear a little bit more about from Denise, where instead of just doing a scan, we actually give lots and lots of MIBG to them and try to get rid of the neuroblastoma.
So is this information available to the parents? Because obviously, if you have sort of a priori knowledge that your kid's not going to do well,
right,
perhaps you as parents would take potentially bigger risks because you know effectively what the likelihood outcome is going to be.
So remember, so 2 things. One, we don't know if doing something different will make it better, worse, or the same. But you're right, you might be more of a risk taker. And what we don't know is whether it's still good to do transplant. Maybe it's after transplant. This is just one approach we're taking to sort of, we don't think these patients probably shouldn't get a transplant if they've responded.
No, no, that's a
Oh, but is it open? So the information, so this is actually published now. And you know, it's certainly been shared at COG for years. I've actually had it in my talks at COG for this task force for years. So I know we always incorporate it into our thinking about whether we should do transplant or not. But and for us, it's really, is there any response versus is there no response? So no response, we tend, I'd say 5 years ago, we maybe still did transplants. These days, we do tend to talk about alternative therapies. And it may be different for different physicians when that change happened. But for example, we have sent some patients for MIBG therapy before doing transplant, if they meet those criteria, for a couple years now. And it'll be certainly easier to do when we have the suite opened at SickKids.
So in the future, just to come back to that, in the future, say there's a new case of neuroblastoma, they come to you, it's high risk, and you don't know if they're ultra high risk or
Yeah.
not. Will the parents know the child is ultra high risk, and will they be informed that there might be different steps?
So, you know, it's hard for me to speak for everybody. One of the reasons to do protocols is to try to standardize how we ask the question, because again, this may not be better. It may just be, you know, maybe worse, I don't know. But for sure, I think it's something that most physicians who go to the children's oncology meetings, other big meetings that we have, should know about these things. But again, we don't know the right thing. And I should mention, there was actually a great abstract at ANR in Stockholm many years ago now, in 2010, where the Germans had a cohort of patients, some patients who had MIBG scans with multiple lesions, who were long-term survivors, 10 years, 15 years, and many who weren't. And they didn't, everybody said, what's different? You know, we all raised our hand, what's different about those patients? And they didn't know. So this is definitely does not mean the child's not going to survive. It just means there might be a higher likelihood. But we probably have to match that with some other information, again, to personalize, I think, the decision making. But there are patients, and we have many we follow, who have MIBG positive lesions that don't change over time. They don't get better, they don't get worse. And those are very complicated for us. So Denise will talk a lot more. This is really because I don't want to steal her thunder. My only slide on MIBG therapy, but really, these are, you know, most of you have children who've had these scans, and you know what the way it works is it's a radioisotope, so it's radioactive iodide that has a little tag on it that tells it to find the neuroblastoma cells, and it works in about 90% of patients. And so the idea of MIBG is, instead of just taking pictures, if you give a lot of it, you can deliver all that radiation to the tumor in a much more effective way than the way we do traditional radiation therapy. And so, as I said, Denise will talk more about that a little bit later. But what about phase 3? This is what's gotten all the publicity and all the excitement. Alice Yu's big finding, activating the immune system. And now it's the hottest thing in leukemia as well. So we led the surge this time in neuroblastoma. But where are we going with the immunotherapy? So I already showed you this better survival. So everyone really who at least has a partial response to transplant and meets criteria, because this is still considered experimental therapy till it's FDA and Health Canada approved, can qualify for immunotherapy. And what is immunotherapy? It's an antibody that recognizes neuroblastoma cells and tries to eat them up, basically. And we give a couple other chemicals with it that help activate the immune system. So it's still a study because it's still only made by the NIH as an experimental drug. But United Therapeutics has been working with us in COG for 3 years at least now, where they've been developing the drug as a commercial drug. And the expectation is there'll be approval sometime in the calendar year 2014, but that gets pushed all the time, so I'm not sure. And then Health Canada will follow hopefully soon after the FDA. Yeah.
So to get the immunotherapy, you have to be enrolling the 14-18?
For in the protocol, you mean?
Yeah, so let's say that I want mine to get immunotherapy.
So-
you have to be enrolled in
So today, yes, when it's over the counter, so to speak, or not over the counter, prescription, it will have to come up with some standardized ideas about that. And then you'll also have to think a lot. We know from work in Europe that CH14-18 alone is probably not as effective as adding the other drugs. So I think there's a lot of questions about who should get it. There's a lot of treatments I'll talk about where we're incorporating immunotherapy into relapse therapy. So there's actually a lot of other ways to get CH14-18 now. Together with other, we think you have to use the 14-18 with something else to stimulate the immune system. It's not good by itself. It needs like a little help. And you know, we're working, POGO's been very helpful. They're working with the government to sort of warn them that this is coming because it's not going to be cheap. So where are we going? So anybody who's had immunotherapy or known anybody who's had immunotherapy knows that there's a lot of toxicity. People often ask Denise and I, is it as easy or hard, depending on your perspective, as chemo or transplant? And it's just different for every patient. But the most common things are pain, fevers, infections sometimes, and lots of fluid retention. The body acts like there's a huge infection going on inside of it. So it's definitely a very tough therapy to go through, especially because by then most of the kids have recovered from transplant, they've grown their hair back, they're feeling better, gaining weight, and then we hospitalize them for 5 more months on and off. So our goal, again, we're very, you'll think we're very genetically focused, and we kind of are in children's oncology group, but is to figure out if there are genes or other predictors to know when patients start immunotherapy if they're going to respond, because who wants to put a child through that if they're not going to respond to it? And so we're working very hard, and there's a lot of very interesting data, but it's sort of not validated enough because we wouldn't want to restrict immunotherapy from some patients till we're really sure we know the markers. And part of this is developing these ways to monitor the microscopic disease in the bloodstream for our patients. So as Indira sort of asked, there are many new approaches, but they're all depending on better ways to activate the immune system, hopefully with less toxicity. And right now there's a study from the NANT, which is the New Approaches to Neuroblastoma Therapy Consortium, that SickKids currently is the only Canadian center that takes part in. And there's a very exciting study that we've now had our first patient receive therapy on, which is CH1418 plus a drug called lenalidomide. And the way lenalidomide works is it takes the cells we think are the most important for CH1418 to work, called natural killer cells, and gets them revved up. And so we think this is really, it works really well in mice, and we think this is the next way to sort of spare having to do the IL-2 and some of the other drugs that we're doing right now. So it's because this is a phase 1 study. Sorry, so she asked whether, thank you, Diana, whether we should do the GM-CSF. So because neither of these drugs have been given together, it's still an experiment whether we can give them together. So we don't actually know if we would need the GM-CSF, but we're concerned enough about making sure we understand the toxicity that we can't throw a third drug in right away. And I think even if we wanted to, we wouldn't be allowed to probably at this point. The other thing we're doing is, what do we love the most? Chemotherapy, because it's what we know the best. I don't have the time, but I think there actually is good, when I say preclinical data, that means mouse and other data to suggest it might actually augment. It seems counterintuitive, but I think it might actually make sense that it would augment some immunotherapy. So there's also a trial in relapse with the CH1418 with some immunotherapy, with some chemotherapies. So that's immunotherapy. I was just going to touch on briefly a couple of other things that are happening in the relapse world. So this is something I don't really have to tell this audience, that high-risk neuroblastoma usually comes back in the bone or bone marrow, and that it's very hard to cure. There's lots of studies to show that. So recently, with a couple people at SickKids, we wrote a review of the treatments of relapsed neuroblastoma. Most people, when they write about treatment for relapsed neuroblastoma, write about all the newest and hottest treatments. We actually wanted to think about that, but also think about what else is sort of out there that people use and try to think how people make these decisions about relapse therapy. And these are just a few. There's 100 considerations when we talk about relapse therapies. But for each patient, again, I think it has to be individualized. It depends what other therapies the patient has received, whether the patient actually has had a response and then it came back, or whether the disease just hasn't responded very well to anything we've given them. And we think those patients are probably very different. There's probably genes there that we don't understand. Some protocols these days more and more require a biopsy for a lot of reasons that I won't go into unless somebody has a particular question. And then there's quality of life. So we're very focused on developing outpatient type treatments because these children have spent 1.5 years in the hospital. And so far I have not seen a big difference in some of the more inpatient treatments. So I think there is an emphasis to trying to balance quality of life with the therapies. And then access, which can mean a lot of things. It can mean IVs, it can mean where you live, but I think that's an important consideration. So there's chemo, which again, I think in our experience and in the Children's Oncology Group experience has been something that patients tolerate very well, especially topotecan and cyclophosphamide, where kids actually not only have a good response rate and can tolerate it for several years, but we actually looked specifically to see what we called the quality of life measure, which was how many hospital days per cycle. And it seemed that it was less than 1 per cycle. And I think it's even less now. This is an older cohort. We know most of these kids go to school most of the time. They come to clinic maybe half a day. So I think, again, I'm always looking at that as well as just the anti-neuroblastoma effects. And there's other chemotherapies, which we and others use. Again, we've learned from the Europeans of another possible combination that we didn't used to use. It's topotecan, vincristine, and doxorubicin. The only thing I'd say, so it works very well in the PSYOP group, but they don't use a lot of those drugs. We do, so I think they haven't seen them before, so it works really well for them. So I just wanted to talk about ALK for a minute because it's all the hype and there's lots of questions about it, and I only have a few slides, but if you have more questions either now or afterwards, feel free to ask. So there's a lot of excitement about it. It has its name because it initially was found to be important in lymphoma, so it doesn't mean it's not as important in neuroblastoma, it just was found there first. And it's actually, happily for us, important in lung cancers as well, because lung cancers to the pharmaceutical companies mean a lot bigger business, so it's actually helped quite a lot in getting these drugs developed. Sounds funny to say it's good, but it is good. So this is just, I love genes, as you guys know. I always have to show pictures, but this is the gene, or the protein actually, of the ALK gene. And this thing in red is the kinase domain. Kinases are things we love in cancer therapy because they're things we can make drugs to. And for neuroblastoma, most of the mutations are in this red kinase domain. And so just a word, because people want to know, should we get tested for this and where do we get tested? And the issue is, neuroblastoma, in addition to being something that is most of the time bad luck, in a very small group of families, maybe 1%, is something that runs in the family, or maybe doesn't run in the family but could run in the family. So in those cases, you should have the ALK mutation in every cell in the body. So we can do a blood test, we can swab the mouth and take some cells off of the mouth, and we should be able to find the ALK gene. But this is like 1%, not even probably 1% of our patients. So this is worth doing if there's a family history or something else that you're concerned about, and we have a list of things we look at to decide if we should worry about that or not. But in just the sort of run-of-the-mill, what I call the bad luck neuroblastoma, or we call sporadic neuroblastoma, about 8 to 10% of patients will have a mutation. So it is worth testing for in those patients.
Test for it in Canada.
So I'm going to show you that. We will soon. We're close. So 10%, the reason we want to test isn't just because we want to know, but there's a drug called crizotinib, and there's been a trial already published. There were a lot of lymphoma patients. They did fabulous, like 90% response rate. We weren't as lucky in neuroblastoma, but of the 27 patients treated, 3 had a complete response and 6 had stable disease. And if anybody pays attention to phase 1 trials, that's pretty impressive. It's even good for a phase 2 trial. Most of the responses were in patients who were known to have a mutation. So that kind of makes sense to us biologists because we don't think it's going to work if you don't have something wrong with it in the first place. So now we're doing a lot with crizotinib. Most of the time we're saying you need to have the mutation to get it because we're not sure it's going to work. If you don't, we're of course adding chemo because that's what we do. And then because we also think, actually in this case it's more than that, because if we might one day want to bring crizotinib to newly diagnosed patients, we need to know if it's safe to give it with chemotherapy. So it's not just to do it to try to be more effective in relapse, but to be able to bring it up front, which is our ultimate goal. And then there's other ALK inhibitors, including one that Sylvain Baruchel will have open at our institution with some European centers that I don't know where else it will be available, but it's not coming through the Children's Oncology Group. It's coming through a Canadian NCIC trial. So how do you test? Right now, the US labs are the only place because it has to be in one of these CLIA-approved labs. And CHOP is generally where a lot of people have sent it, though there's many choices now, and I'm not sure there's a reason other than price to send it one versus the other, as long as they're all approved. I have personally been working very hard with our pathology department, and I think we're super close now. I don't want to promise a date, but I'm hoping by around the MIBG opening sometime around then that we'll also be able to start testing for ALK mutations. So
And when will you test for ALK?
So that's another great question. So for sure, I think for relapse, we would test. I think for high-risk patients, it's worth knowing, and we're actually going to start doing it in the cog biology for some of these patients from the beginning. And then everybody else, I think it has to be a decision. You can get it pretty fast, so are you going to do anything with the information? And it's complicated because it depends on how the tumor was saved, if it's easy to do or not, or if you want fresh tumor. And yeah, exactly. But you can do it on stuff left over in pathology. It just may take a while. That way you might have to send a few samples.
Can it be done at the very beginning when the child is just diagnosed?
So now Indira is asking if the ALK testing can be done at the beginning. And it can. It's unclear yet whether you can develop them as well. So in other words, if you have it in the beginning, that's helpful. But do you need to test later in case you developed it? We don't know.
So the ALK is something you can develop as well. That's the thought.
So it's not known. So these are the kind of things people say, but as scientists, we like to see their data to understand that. Because if everybody's seen it once, we don't know what that really means. We want to know if that's really true. Because you don't want to do the test 20 times if it's not going to tell you anything. And then the other part about that is we know some of the mutations are important, some of them may not. So we have these things in the mutation world called drivers, which we know are important. They drive the cancer. And then passengers, which are probably just there because the genes are a little messed up in the tumor cell, but they're not important. And so you wouldn't want to treat a driver a passenger. You'd only want to treat the driver. So there's lots of other drugs, and I don't have time to go into all of them, but in case you hear the names, some that are kind of exciting, again, more in combination, because one drug's never going to fool neuroblastoma. Aurora kinase inhibitors, which from what we know in the lab might work better in MICN, but it's not totally clear. These mTOR inhibitors, which are related to drugs used for solid organ transplant patients, like liver transplants and heart transplants, called rapamycin drugs. And Sylvain Baruchel carried out a trial at Sick Kids based on some lab work done by David Kaplan's group, and that was funded by a combination of James Fund and Solving Kids Cancer, and that was completed and recently published. And so I think, again, we don't think by themselves they're the answer, but we know they're well tolerated and that they're very effective in some patients with neuroblastoma. And then drugs that block the blood vessels or anti-angiogenic agents. There's a trial that'll be coming at Sick Kids, again, led by Sylvain, who's one of the funded James Fund investigators. I can never say it. Sylvain does really well. I think it's pazopanib. And then MIBG therapy, which we'll hear more about. And then, there's more. I didn't even put everything on the list, but a drug called DFMO together with a drug called celecoxib that both Sylvain and I had studied in the laboratory for a long time is coming through NANT. Accutane or Cisar.
Coming to Canada?
Yeah, it's actually somewhere in the ethics pipeline right now. Yeah. It is. It is for disease. It's not for sort of no disease, but it's for patients who have evidence of disease. Verinostat, which is a drug that has maybe some more efficacy for the bone, together with Accutane, and then a list of lots of other drugs. But I think what's really coming next is better decisions about what therapies based on genes. So just like ALK, we need to know if the particular patient will respond to the particular therapy. And we're unfortunately a bit far from that right now, but I think that's kind of where we need to go. More than just new therapies, it's more who should get which therapies.
So is that the sequencing?
So sequencing is kind of the thing everybody has their hopes on, and I think in the adult tumors, it's going to pan out for some patients where there are more mutations and more genes that have drugs. It turns out, and I don't have the slide this time, but in neuroblastoma, about 300 or more now neuroblastomas have been sequenced, where every gene in the entire neuroblastoma cell has been sequenced. And what they found is 8% of the time ALK is mutated. After that, it's sort of like the pie gets thinner and thinner and thinner. So it's not like lung cancer where 20% have this, or breast cancer where you hear about HER2, or those. It's not going to be that simple. And in fact, even the people who've spent the millions of dollars, like John Maris, doing this are now saying, we need to come up with alternative ways of coming up with new drugs, not just sequencing. I think for some patients that'll help, but I don't think it's going to be the answer. I think it's not just one gene either, because you can look at genes in other ways besides sequencing to see who's up and who's down, and there's just other ways of doing it. So I think that's where we're going to have to go. I always feel like it's more complicated in neuroblastoma than for all the other tumors. So there are some new strategies we're using. So we used to take a new drug and just give it to a patient by itself and not give it with other drugs. And we kind of know in the relapse neuroblastoma setting that's probably not the answer. So there are these strategies now on this side of the Atlantic called pick the winner, and in Europe they call them drop the loser. So I guess it just depends if you're a glass half empty or, and these are phase 2 trials where we take a drug with some signal of activity, and we take the patients and we all give them the chemo we think works pretty well in relapse and add drug A or add drug B, and then see who wins at the end. It's not perfect. It doesn't take into account genes and lots of other important things, but I think it's a step in an improvement rather than saying we're going to give you one drug and see how things go. So I think I hit on most of the challenges, especially already with the heterogeneity of neuroblastoma. And I think the other challenge, and I'll show you just a couple of slides from the lab, some brief examples, is the models and how we study this in the laboratory. And maybe if we're not studying it right in the lab, we're not picking drugs that we should bring to the patients. And so that's where James Fund has been really helpful in getting some of these early studies started, because for us to come up with novel ideas in the lab, it's sometimes very tricky if we don't have a lot of data to already show it works. Then if we have a lot of data to show it works, somebody else will give us money to get even more data. But what we want to do is take some, I think Sid likes to call them the out-of-the-box ideas, and really give them a try, even if they're all not going to succeed, try to get some more high-risk ideas going, hopefully high-risk, high-yield eventually. And I think that's worked really well for us. And at the forefront of that is really our efforts at Sick Kids and internationally with getting samples from patients. Once all the clinical stuff is done on the samples, making sure we don't just do things with cells that we grow in the lab forever and ever, but that we actually look freshly at cells that come from our patients. And I think there is a strong international and local collaborations for these things.
Does Sick Kids have a biobank?
We do, and I also am part of the COG biobank, and they're... Yeah, and at COG we have 8,800 samples, which are all annotated with a database, so it's quite extensive. And it's pretty easy to get samples. It's a little harder to get all the privacy outcome data, but we can code that and give that to people as well. But that's been a huge, rich factor, because as common as neuroblastoma feels in this room, I think everyone knows it's not common enough as breast cancer or prostate or something.
And so these biobanks will they get linked?
So there's an effort right now through the International Neuroblastoma Research Group, which has a clinical database, to link virtually, because you can't, if you start dividing samples, then there's nothing for anybody, but to virtually link them. The truth is Children's Oncology Group has the richest one and the one that everybody comes to. The other ones are much smaller, so it'll probably help our international colleagues more than the North American.
I know BC is getting a biobank.
Yeah, everybody likes to do their own biobank. It's kind of, but what we do also, as I think some of you have come here before know, is we also try to grow the cells and try to test them on drugs right away and things like that. So it's a little different than the biobank, because you can't do that with a biobank. You have to actually nurture the cells right away when they come from the bone marrow. So there's 2 projects I want to give you guys a feel for, because they're very exciting and hopefully addressing some of these challenges in relapse. One just follows what we've talked about, that neuroblastoma, when it relapses, is usually metastatic. So this is just an example of a tumor. I'm sure lots of people have seen these, but these very aggressive tumors, you're looking from the feet of a patient. This is the liver, this is the vertebra, so the backbone, this is the kidney, and this is this big tumor with lots of vessels stuck in between. So as you know, I'm not a surgeon, that looks like it would be impossible for me, but our amazing surgeons actually are able to get most of these tumors out. And most of the time when it comes back, it doesn't come back here. As we talked about, it comes back in all these other places, the bone marrow, less frequently some of these sites, but the brain more and more. So how are we going to take care of that? The problem is in the lab, we don't usually look at all these different sites in a mouse, for example. So Kelly Fathers, who's a postdoc who works with David Kaplan as well as myself, wanted to solve this problem. And so the question was, how can you make a mouse that gets neuroblastoma metastases to the brain and to the bone? And then I was preparing this last night, and my daughter was looking at this and asking, she's 10, and asking me what this was all about. And I said, well, we're going to give mice neuroblastoma so we can try to cure them, and then we can give the kids the medicines. And she said, but why are mice like kids? And that's actually the question. We want to make the mice look like the kids, and that's what we're trying really hard to do, because most of the mice we use in the lab don't have the same disease that our patients do. And so this has been Kelly's question, and she's came from a breast cancer lab and is adapting a lot of the techniques she learned in breast cancer, where they've been doing this for a long time, to neuroblastoma. So the disadvantages of these models, these mice we use in the lab, are they don't get the same metastases, and if they do, they get itsy bitsy little ones, not the things we're used to dealing with in the clinic. They almost never get them in the brain, and this is becoming a bigger issue for us now. And there's not a way to do little mouse CTs and MRIs and things like that. So we wanted to address all these questions, and I'll show you some of those pictures. So, normally when we do our various different ways of giving mice neuroblastoma, they get some in the lung, which we almost never see in neuroblastoma. They get itsy bitsy things in the bone, a little bit in the liver maybe, and then they get stuff in the adrenal gland. But they don't really get the other things reproducibly. So if you like mice, you won't like this picture, but hopefully. What Kelly does is she takes these fluorescently labeled cells, she injects them in the heart of a mouse, and then they go to the entire body. And these mice get, this is an x-ray of the mouse bone, they get metastases in the bone, they get them in other places. She takes out the cells from the bone, puts them in the dish in the lab, grows them up again, takes them out, puts them back in, and starts the whole process. And each time what we hope we're getting is a more and more evil metastatic cell. And maybe one that likes to go to the bone or likes to go to the brain. So that was our idea. And then, it's all about genes in the end again. So we take all the RNA and DNA from these cells and we do these microarrays and we look to see if the genes in the bone look different from the genes in the abdomen. This isn't the mouse, those are human pictures, but I'll show you the mouse. So this is one of her friends, one of her mice. This is a control mouse. Now the reason they light up is we have this fancy camera we use. There's like this whole radiology department for mice at the Mars building where we work, so where they can do MRIs, CTs, and this thing called xenogen, where they can look for these fluorescent cells, and the more yellow it is, the more cells, and then green's a little less. It's kind of like a bullseye. And so we they anesthetize the mice, just like we do children, and then we put them in the imager, and we see where the cells have gone. And the control, you can see there's very few, and then you can see essentially these have lots and lots of lesions in different places. These are the limbs, so these would be like femur mets or leg bone mets. This is the jaw, and this is just to show you that when we take out the jaw, it really was the jaw of the mouse. So again, if you like mice, you're not going to be happy. And these are CTs these are very fancy CTs, and I just want to show you the hole in the jaw of the mouse. That's all you're supposed to see. So again, this is exactly what we would see in patients, and this is what we're trying to mimic in the lab. And this is a limb of the mouse. Limbs look a little funny on CT because you can see everything, but these are fairly normal looking, and then you just see lots and lots of holes in the mice who have the metastases. And interestingly, and something we were hoping, because nobody has a model for this, was that they get some brain. These are MRIs of the brain looking straight onto the face, and this is a lesion. Here's a couple more lesions. Here's another one on the MRI. So they get brain metastases. So this to us is very exciting. It's obviously not good for the mouse, but it's very exciting for us. And we've already identified some genes that are increased in the metastases that are not increased in the initial cells that we inject in, so we think they're being selected for. Some of these we've looked, and they seem to be genes that if patients have them in their tumors from the COG biobanks and those things, that the patients do worse, so that tells us maybe they're getting metastases, so maybe this mouse is really telling us something about kids. And some of these may even have drugs that would work against them. So that's really the holy grail for us. And then the other thing is, in the lab, when we find a new drug, an ALK inhibitor, whatever, the way we study it is we inject some tumors in the skin of the mouse, usually in their leg, and then we treat the mouse with the drug, and we say, does the primary tumor shrink or grow? So that's not what's happening in our patients who have metastases, and especially who have brain metastases, because fighting neuroblastoma in the brain is probably the hardest place to fight it, partly because it's hard to get drugs into that area. So now maybe we have a mouse where we can give the mouse a drug and see if the brain lesions get better. So this really to us has multiple uses, finding new genes and also a model before we go to phase 1 trials, because we're not so good at predicting which drugs are going to work in patients. And what we're trying to do now is actually, instead of taking all the cells we grow in the lab, take cells straight out of bone marrow, like when a patient's having a bone marrow and we get consent to get a little extra, try to put them into the mouse and see if we can recapitulate this whole thing. So that's harder, because we got to put the fluorescent tag and do lots of things, but that's the holy grail of trying to come up with different therapies for different patients. And some of those therapies we're using other ways. These are just a couple of the other trainees, some from my lab. Also, we work very closely again with David's lab, David Kaplan's lab, trying to find new and old drugs that'll target these metastasis cells from the mouse as well as cells from the bone marrow of our patients. And you've probably seen some of these before where we've been doing this for a while, but just with different drugs, where we take the cells, put them in these big plates that you can see here, add different drugs, add something called Alamar Blue, which is a dye, and then the robot adds the drugs, and the robot measures the dye. So you don't have some poor graduate student just sitting there for hours doing it. And then we get a bunch of results that look something like this on the next slide, that tell us different drugs that work against different cells. And from that, we've come up with lists of drugs now that we're going to study both in that mouse model as well as hopefully ultimately in our patients. And we've been looking at some of the patient's cells straight from, again, surgery and the lab to see if we can identify whether these drugs work. So mostly we're looking for these kinase inhibitors again. So just like ALK, what kinases are is they're enzymes that are very important in cancer cells. Essentially, they take a phosphate from one protein and add it onto another, but they're very susceptible to being blocked, and often that will even stop the whole growth pattern. So in leukemia, there's been a lot of success with a drug called Gleevec that even made People magazine years ago, and then ALK inhibitors are the first form of that in neuroblastoma. So we've found a few, and I'm not going to go through all those slides right now. But this is just one of them in mice, and this is again a Kaplan-Meier, but with the mice now. And these are the mice that didn't get our drug. These are the mice that got our drug, and these are the mice that didn't get our drug. And that's just one cycle of the drug. And we can already see that some of these drugs are working in the mice to prevent them from dying of their neuroblastoma. So we have a whole list of drugs, and I won't bore you with all of those right now. But this is really, as I mentioned, this is like the final slide really. What is our holy grail is to take patients' samples from the bone marrow, and this is stuff David and I do together, well, with a lot of help from amazing trainees in the lab, take those cells, test them both against what we call recycled drugs that have been used for a lot of other indications, as well as these new kinase inhibitors that we get from our chemist collaborators, give them to the mice, see what happens to these tumors, and then hopefully take them to clinical trials together with Sylvain Baruchel and others in our team in the neuroblastoma program. And really, hopefully, that's where we're going to be able to go with some of this research. And then there's a lot of other things we're doing. And I'm just going to probably end here, even though I have a couple more slides, but just to show you that we're looking really a lot at genes. We're working with computer scientists, other collaborators across North America, working really hard with the primary cells. We have a lot of clinical projects as well, many of which are supported through the James Fund as well. And I think one of the most important things that we've been able to do with not just money raised by James Fund, but many of the other amazing groups and families that have been behind us for so many years is supporting young scientists to come to our labs to work on neuroblastoma, because then they go back to their countries and start working on neuroblastoma. Not to mention that their bright minds and energy really help us come up with amazing research. These are just some examples of some of the places. And it's really led to some amazing collaborations for all of us. And we've started now we call it a neuroblastoma fellowship or translational fellowship, and we recently had our first fellow. I'll just show you his picture because we like to show his picture. This is Daniel. He's actually now a staff at Great Ormond Street, which is really one of the biggest hospitals in Europe, and they're quite leaders in the PSYOP protocols for neuroblastoma. He was our first fellow, supported by many sources, including the James Fund. And he did a lot of projects in the lab as well as a more clinical project, and he actually got this amazing award, which we've never had at Sick Kids for any of our trainees, where he, at this meeting of 20,000 people, had the highest graded or ranked abstract of all of the trainees in pediatrics. And we have lots of plans to work closely with Daniel to do some things across the Atlantic, and he's now our PSYOP spy. We have good relationships with PSYOP, but now we have our own spy embedded in the PSYOP. This is going to go online, so I don't know. But I'll skip his stuff. And just one other thing that we're doing in collaboration now with the UBC group. We're in the middle of writing a grant, and we've had some generous support from the James Fund to get this started, where we're actually looking at something I think is interesting, and I'd be interested afterwards in hearing people's opinions. There's a neuroethicist. She actually does a lot of work on how patients make decisions about dealing with spinal cord injuries and treatments, but she got very interested in neuroblastoma for a number of reasons. And she wants to work with us together with the folks at BC Children's to try to understand how families make decisions about treatments for neuroblastoma. So it's a complicated question, We want to look at the media, how people use the internet, how people use the information they get from their caregivers, but really coming out of it, not just study it, but figure out if there are some tools that we can help develop, and she's done a lot of this in neural injury world, come up with some tools that would maybe be helpful for making some of these complex decisions that cross borders and cross countries and things like that, and I think it's going to be very exciting. And we're also interested in some late effects things related to all the scans we're doing on our patients, but that's for another time. These are just some of the people, some of whom I talked about. This is people from my lab, Kelly, who's with David as well as myself, and just lots of people through the years. And of course, we couldn't do anything without our amazing nurses, nurse practitioners, social workers, and everyone who helps us with the startup money for all of these amazing projects.